out there in virtual reality, where it's Valentine's Day here in Canada, or the more politically correct Singles Appreciation Day. But truly exciting.
What Appreciation Day?
Singles Appreciation Day. SAD is the acronym. But the truly exciting news today is, of course, our presenters, David Henry and Sue Schultz. I'm just going to do the introduction of David Henry, who received his MD degree in medicine from the University of Glasgow in 1972, followed by internship and residency equivalent training in internal medicine from the joint colleges of the United Kingdom.
Yes.
Let's get off. And then various certificates over the years, including general internal medicine, clinical pharmacology, and gastroenterology. He is currently both the president and the CEO of ISIS. Where one job starts and the other begins, it's just not clear to me.
Come to my office later.
He's a full professor at the University of Toronto, as well as an adjunct professor at the University of Newcastle. Lots and lots and lots of accomplishments. I was particularly impressed by over 240 Medline articles and still going strong. He's a co-I on buckets of major grants, and he's still so old-fashioned that he lists his spouse and children on his CV. And thank you for dressing up today, David.
Thanks, Don. I really need to do something about the detail in that CV. It's quite old. So,
it's always revealing to read a person's CV.
yeah, and I think my son's age is probably listed as 13 on it. 13, he's now 31, so how things are going. Thanks, and thanks for the opportunity to, on behalf of both Sue and I, to talk today. We briefly presented some of this at a staff meeting recently, and Sue has also did a presentation yesterday within ISIS, so there's been a bit of exposure to this. There's a sort of voyeuristic element to our interest in this, and we should get that out in front. And we always like to find out what other people are earning. But this is not about earning, and I must stress this. There are two issues here. It's what do doctors cost, and what do we pay them? And they're strongly related, highly correlated, but they are different concepts. As a province, we're interested in how much they cost and what the value is from it. It's really important. Our voyeuristic selves are interested in what they're paid as individuals, and we're going to give you both of these components today. The issues are value, and we don't give you value here. We don't try and give you value, because we need to know what the output is, and we haven't got measures of output. We've only got measures of input here, which is some part of the payments that are received. And it's been difficult to do this, and Sue Schultz is the person who's really done this, and she's going to walk us through the methods and results, but I'd like to pay tribute to her because she's really maintained this capacity within ISIS over many years, and how important it's proved to be at different times and also into the future that happened. Now there's another element to this. The really exciting reason why we're presenting these data today is the work that's been done since the report was released. You may think that systems are doing an upgrade of the network at the moment. That's what they're saying. What they're doing is establishing a web crawler that is visiting Facebook pages to find unattached ophthalmologists and radiologists. And the iPhone application detects their GPS signature and tells you, vibrates if you're within 5 kilometers of one. This is our future, is selling iPhone applications of this type. If you don't get that joke, you soon will when the numbers come up on the screen. And I won't tell you who's in the team that's developing the iPhone application, but some of you could probably guess. Let's get back to the numbers and the data. There's a lot of people involved in this. I'm not going to read through these names, but I particularly want to thank Nancy McCallum and Susan Schiller, because there's a large KT element to this. This is a big report. It was a messy report. they had to work, not only working with Sue, which is straightforward, they had to work with me as well, and that was tough. So, but there's a long list of people inevitably that are involved in this type of work. But as I say, Sue Schultz was the person who's done most of the work. The collaboration with the ministry here is absolutely critical because there are a number of people here who have been critical, and there will be others that are not mentioned, in accessing the multiple data sets that are brought together to actually calculate what the payments are. Susan Fitzpatrick in particular has led the working group. But the idea, and I want to just record this, is that the idea came from us. The idea to do this was out of a sense that there should be public reporting of these numbers. And the conversation that led to this was an important conversation. It wasn't driven by a desire to inform the negotiations between the ministry and the OMA, even though it is part of that consideration and that negotiation. But the thing that drove it was a sense within ISIS that this information should be brought together and publicly reported. Now, the background to this in Ontario and more broadly in Canada is quite interesting. You can just sit and eat that in front of me, aren't you? So the background's pretty important because unusually for countries, through the 1990s, there was strict capping of payments across Ontario provinces, and this has been reported by a number of ISIS scientists and obviously by others throughout the country. And the numbers of physicians who could enter practice and bill under OHIP was restricted. This has been it was a significant event in Ontario history, and you'll see the impact of that when Sue shows you the payment levels during that period. And then this really quite dramatic change in policy to shift from a restrictive and a capping approach to containing physician payments to one that tried to get value, that tried to reverse what appeared to be an outmigration of physicians, in particular key groups, primary care, some of the consultative specialties, you'll see them later on. So there was an attempt to correct that by giving incentives, by removing the caps, and so on. These are the report objectives. They're fairly straightforward. I'm not going to read through them. I would stress the notion of public reporting, even though the report is on our website and is publicly reported, but it's also on the table that sits between the OMA and the government negotiators at the moment. There's one of many pieces of documentation sit on that table. It's not the single or even necessarily the pivotal report. We will be asked to do more by them, though, and that will be to inform both sides of the negotiation. Please understand in this that ISIS doesn't have a position on the negotiations other than as a provider of information. We really want to know what is the relativity in payments across the different specialty groups. How has that changed over time? Also, and critically, as the ministry shifted, as the government shifted from a fee for service payment structure, which is a common one in many countries, to a more managed alternate payment plan, what's the impact on the specialties that are most affected by that, including family practice? The chronology has been going on for quite a long time. So we've been asked, and I've been asked by journalists actually in the last week, was the timing of the release of the report accidental? It was like we produced it in a week. It took... Yeah, right. Absolutely. So it actually took quite a long time. Was the timing of the report, were we under pressure to release it so it could inform the negotiations? Absolutely. But the work that had been done to compile this had been going on for a long time. Why did it take so long? We'll see a report on that. It's really got to do with data access issues. This is my time to segue. Okay. Sue is going to pick up and talk about the data sources, the methods that she used, and the results. And I'll pick it up at the end to encourage a debate. please do a sharpened drawing of noisy celebrations when you see the amounts of money. Trying to maintain a calm demeanour through the rest of this presentation. Sue, thank you.
Okay, thank you, David. So I'm going to take you through how we did it and then go through some of the results. Obviously, I can't show everything. There's some 120 exhibits in the report, so we've done some picking and choosing, and hopefully we'll touch on what most people are interested in here. So these are the data sources that we used. OHIP fee-for-service billings from 1992 onwards. The OHIP architected payments, which are monthly payments linked to billings. So they're incentives, bonuses, premiums that kind of get summed up and rolled up, and then a payment is spit out at the end of the month. And the primary care network capitation payments, these are for the earliest primary care models. We have information about the academic health sciences centers through the governance, and we know which physicians are in which group, under which governance, and we have monthly payments for that. And a data set called the GAP, the Generalized APP Payment Database, which includes basically everything else. All the payments under APPs, the emergency department AFAs, and other contracted agreements. Also includes information about miscellaneous payments, one-off payments, and even some charges. We were never able to obtain useful non-primary care alternate funding payments prior to 2005. I've got the word useful there, and I have it asterisked because we did get some data, but it turned out to be a lot of different things combined, and we were not able to separate or identify what was what. So we weren't able to use it. So we have primary care data is almost complete. The APP data from 2005 onward is pretty complete, but there's a gap between about 2000 and 2004 where there's missing data, and this affects certain specialties like emergency physicians, hematology, and oncology. When we looked at the payment levels that we were getting for those specialties, it dropped dramatically during those years, and we decided to just exclude those years. In addition to the missing data, there were public payments that we were not able to get. We don't have any information on payments through hospital global budgets. We don't have any information on payments through the WSIB. We tried, and we just recently, we think we've received some of the psychiatry sessional payments, but we haven't looked at them yet, so we're not really sure what we've got. But they've, and there's a pot of money that's administered by the LINs, and we don't have that for mental health payments, mental health sessionals. And we don't have the hospital on call, and I know that a lot of physicians are concerned. I get a lot of questions about this. Do you have the HOC? Do you have the HOC? No, we don't have the HOC. In the future, I think we will have it, because I think the ministry is going to be administering it in the future, but right now it's administered by the OMA, and we don't have any information on how it gets divvied up. So these are the inclusion-exclusion criteria from the fee-for-service billings. We excluded technical fees and all of the L codes. We didn't include any lab billings. From the architected payments, we excluded, within that data set, there are some things that look like payments, but they're actually calculations. And so we needed to exclude those. Plus we excluded summary records that were summed up into the group. And from the GAP, we excluded admin. There's a lot of payments now that are being made to the family health teams to cover administration, to cover non-physician providers, to cover IT, other kinds of infrastructure. Even some of them get their rent paid. all of that was excluded. And then from all other data sources, from all of the data sources, if payments were missing both physician number, FISNUM is the encrypted physician billing number that we use here at ISIS as one of our linking variables. And group num is the encrypted group billing number, OHIP group billing number, and that's the other linking variable that links to all of our other data sets here at ISIS. If both of those were missing and we couldn't figure out what they should be, then those payments had to be excluded. Any questions so far? So then the next thing that we had to do, and I apologize to people who were at my presentation yesterday because some of this you heard already, but I'll go through it fairly quickly. The next thing we had to do was to assign the payments to individual physicians, because what we really wanted to get was what individual physicians were being paid. The ministry, I mean, you can get from the financial, for the Ministry of Finance, you can get the totals, how much is paid out through OHIP, how much is paid out through the various different program areas. You can get the totals, but what we didn't know, and what we all wanted to know, was how was that being divvied up among the 25,000 or so physicians in Ontario. So going through the data sources with OHIP and the architect of payments, they have the physician billing number on the record, and so that was relatively easy. With the gap, it was a little bit more difficult because I had to use a hierarchical approach where if it had a physician number, then it could be assigned to a physician. If it had a group number, if it depended what kind of group it was, and then we could use the CPDB, the Corporate Provider Database, to identify the physicians. And then those payments had to be divided up equally. Or we also were given a crosswalk that helped us identify groups. And I should point out here that there were a lot of payments through the alternate payment plans that are actually block payments made to groups. They're not actually paid directly to physicians. And so in the end, we decided to just divide them up equally. That was the recommendation from the ministry, and that's what we did. So it's probably, I mean, it's an estimate, and it's probably not 100% accurate, but it'll be in the ballpark. The other thing that we had to do was decide which specialties, because we wanted to look at this by specialty. We excluded lab physicians right off the top because their incomes, their payments are kind of unreliable. Some of them get a lot from hospitals, so we figured they were, the data were probably incomplete. Others, sometimes it gets mixed in with commercial lab data, and so we just decided to exclude them completely. As well, there are physicians who look like lab physicians in the data. So we decided that if more than 50% of payments were from lab billings, we would also exclude them. There were some small specialties who had less than 50 physicians in 2009-10, which probably meant they had even fewer back at the beginning of our study period. So they were probably, maybe 30 or 35 physicians back then. And we decided to exclude them as well: infectious diseases, occupational medicine, and medical genetics. And then others were combined. So thoracic surgery with cardio and thoracic, pediatric cardiology with cardiology, pediatric surgery with general surgery, and community medicine with the GPFPs. And then the ministry asked us to define emergency physicians as any physician with more than 50% of their billings in the emergency department. So that includes a lot of family physicians with an emergency medicine certification, and and also a lot of family physicians who work in the emergency department. Then we grouped them into 6 groups, and I'm not going to read all these, but basically the GPFPs, the primary care physicians, emergency department physicians, anesthesiologists are left alone because they're different. They didn't seem to fit with other groups. And then we have the medical non-procedural specialists. These are physicians who work who do primarily office-based work, consults and visits. Then we have the medical procedural specialists, and then the surgical specialists.
Where's radiology been? Sorry, I didn't see radiology.
Oh, I guess I
Probably
forgot
there.
them. Yeah, and then, oh, you're right, I did forget them. Then imaging specialists is the other group. Thank
They
you.
don't make any.
Yeah, they are in there.
Not a big enough group to count.
They don't make enough money.
Numbers, 90 in billings.
How do you know, Jack?
So the analysis itself was relatively simple. Once all of these decisions it was the real challenge with this project was in the definitions, was in who's what, how do you deal with the different payments, where's the data from, what does this mean, does it get included, does it not get included. Once those decisions were all made, then the analysis was relatively simple for each specialty, and overall we present the median and percentiles, we present means by head count and by FTE, and then total payments as well. And each one of them has a different purpose. The total payments, that is of interest to policymakers, to budgeters. The median and percentiles shows the distribution within the specialty, and the mean just gives you the overall average, but on average, what do physicians earn? We also did an additional analysis for GPFPs, looking at the primary care models and how those have impacted on payments. And then we did some summary tables comparing changes over time. One of the measures that we needed to calculate in order to do mean by FTE was to calculate the full-time equivalent. Traditionally, ICES has had a method of calculating FTE using billings and shadow billings, adjusting up the shadow billings, which are in the data at a 0 payment, under the assumption that the adjusted shadow billings will approximate the level of the salary. But we decided, since we had all the payments, let's recalculate the FTE using all the payments. And it has made some differences in some specialties, and we still need to do some testing with this new measure.
What is shadow billing?
Shadow billings are when a physician is paid on salary or capitation, they still need to submit a billing, so that the billings then are used as a way of tracking utilization. And so a physician submits a billing as if they're billing fee for service, but there's no payment amount. And under a lot of contracts now, physicians get a premium for that. They get up to, well, anywhere from 10 to 30% of the value of the billing. That's the formula. Okay, just a few notes before I get into the results. All the amounts are gross, so we haven't adjusted at all for practice costs. This is just what the physicians are paid. There was no minimum threshold used. CIHI, if any of you have looked at the CIHI report that came out, they use a minimum threshold of $60,000. And they also, when they're calculating an average payment by specialty, they only include physicians whose payments are more than $60,000. We didn't do that. As long as you had any payments at all, you're in the mix. The calculations only included physicians for whom we have payment information. So if in our physician database, we know who's designated as active by the Ontario Physician Human Resource Data Center. But some of those physicians who are supposedly active don't seem to have had any payments. So those are excluded. And the physician supply counts also only include physicians for whom we have payments.
Sue, can I ask you a question?
Yeah.
Do you know why Kai does that? The minimum?
I think because they're trying to estimate only for full-time or for, you know, I think they figure if physicians are billing less than $60,000, either that's not their main way of being paid. See, they only use fee-for-service still, so either fee-for-service isn't their main source of income, or they're working very part-time. Yeah.
You adjust for inflation, and how did you do so? You did. Did you adjust for inflation?
Only on one of the slides that I'll show you. No, these are all just as is. Okay, so so this is the overall median and percentiles. In 1992, physicians were earning on average about $170,000. And in 2009, 17 years later, it was just under, it was about $280,000, the median. And the 90th percentile rose from about $360,000 to about $590,000. One thing to keep in mind is that the spread of the distribution is nearly constant. So the relationship between the 90th percentile and the median is the same in 1992 as it is in 2009, even though it looks like it's spread out.
This is unadjusted.
This is unadjusted. Unadjusted. These are in actual dollars. Yeah. So this is your comparison with inflation. The dark line here is the 1992, and then adjusted for inflation all the way through. And these are the actual payments. So you can see it was basically constant with inflation up until 2000. This dip here is probably more related to lack of data, missing data, rather than an actual decrease in income. But from 2005 onwards, we have complete data, and we can see that it has substantially increased beyond the rate of inflation. I'm just going to go back one. So this is the time when the payments were capped through the 90s, and you can see that it's very, very flat all the way through here.
Sue, can you go back?
Yeah.
How did you adjust for inflation? Because there's many different indexes, and there's a basket of services that are healthcare and
Did you use the
Ontario
CPI
specific.
or?
We actually used the Royal Bank of Canada inflation adjuster, which is
So it's
national.
overall.
We didn't use the Ontario specific figure, did we?
Well, I've done it both ways.
You've done it both ways.
Yeah,
I don't
I'm
think
not
it
sure
made,
which
it didn't
is
seem to
one
make
way.
very much difference
Yeah.
whether we used Canadian or Ontario values. We
Yeah.
tried a whole slew of different ways. This is the Royal Bank of Canada adjustment for Canada.
So, I mean, were there any worries about differential missing data, and in particular in the extremely remote years of the 1990s?
Like what?
I.e., if there were some other sources of revenue beyond OHIP that were in vogue in the around 1993, 1994, that then
Oh.
sundown,
Yeah.
might that
There,
change the profile? And would it change the profile a lot?
I don't think so. There were a few primary care programs, the community health centers, a few HSOs, and then there were a few large institutions like the Hospital for Sick Children, who have been on an AFA forever, and there's and SEMO in Kingston. But those are really, you know, in the whole scheme of things, over 20,000 physicians, it's really quite small. And as I say, there weren't a lot. Like everybody that we talked to says, in the 90s, it was, you know, 95% or 98% fee for service. It's very little. I don't know. Maybe you guys from the ministry can speak to that.
No, I just have a question. I'm
Okay.
from the ministry. So, can you clarify more on the dip there, 2001, 2002? You said you believe that is due to bad data. What happened there during that time?
We don't have the data.
Oh,
So there are alternate payment plans that came into effect there, and we don't actually have any of the payments until 2005, just because of the way the information was stored at the ministry. You know, I don't want to blame them, but they've created a wonderful data repository that starts in 2005, and it's very complete, and it's quite wonderful. But a lot of these contracts started way back in 2002, 2003, 2001, and we don't have any information about, I mean, we could extrapolate backwards maybe, and maybe we'll try to do that for the next update, but for this round we wanted to just deal with the information that we had. We didn't want to, you know, do extrapolations, and didn't want to make any more assumptions than we had to.
Can I ask a question?
Yeah.
You're comparing it to inflation, but if you compare it to gross domestic product, which is probably a better measure of the wealth of the society as a whole. And most negotiations with any employees is based on domestic
GDP.
product. Yeah.
Mhm.
Inflation is a raw number of just, as you know, just the artificial increase in value.
Yeah.
Well, there's a whole series of things you can do. I mean, you can price purchasing parity adjust it. You can make it as a proportion of GDP. You can make it a proportion of what's now GNI. I mean, there are a number of ways that we can do it. When you're talking about workforce statistics that are put into the public domain, as far as we can see, the value that is typically used internally within a country is adjusted by the equivalent of CPI. I think GDPs are more often used. I'm not saying it isn't used. Clearly, GDP is growing rapidly, then it is an important measure. But it's, in my experience, limited though it is, it's most used for international comparisons as a way of showing the proportional change in different countries that put different GDP
The
growth.
current health report just introduced is going to be based on transfers based on gross domestic product, because that's a better measure of the actual wealth of society. And based on this graph, physicians actually had no real increase in income for the first 10 years of your graph. So basically it was stagnant, where
That's right.
society probably had a gain in wealth during those years. So I'm just saying it's a bit artificial to compare it to inflation alone.
The dollar was 59 cents
Yeah.
then, and if you're going to university in the U.S., you were paying double what it would. I mean, those were very hard years for Canada.
I think you'd have to look at purchasing power parity. What could you actually do with money? What could you purchase through these years? There's a lot of calculations you can make. But remember, the important thing was government policy to cap it. If you go back and look at the legislation that was introduced, and those of you that have lived through it and worked through it will know that there was a clawback of money. There was no surprise there. It was quite clearly, and it wasn't just Ontario, it was pretty well, I think, all of the states, provinces, forgive me, from Australia, capped income in one way or another. So it's a very clear result of that.
And just a second follow-up question. In October 2006, around then, all the imaging specialists who were partly paid by global budgets and partly paid by fee-for-service switched to 100% fee-for-service. So there was not a real increase in income, there was just a real change in how the billing
How
was.
it's paid.
When did that happen?
October
2006?
2006, it went from
You
all
can speak to the
inpatients-
graph that's coming.
all inpatients CT, and, all inpatient studies except for ultrasound and angio were paid globally through global budgets, based on the imagers negotiating with their individual hospitals.
Okay.
The NASCO in the 2000 round of negotiations around that time switched, so then all imagers had to bill directly to OHIP, and it no longer came out of global budgeting. And as a result, there was an artificial peak in imaging billings.
Interesting.
Can we just follow through? If you look at the Sunshine list, there are still radiologists that are identified as being paid salary under the Sunshine disclosure as recently as last year
Yes,
for certain institutions, I think.
yes, sick kids in particular.
Sick kids, yeah, yeah.
Any radiologist that's salary, similar
Yeah.
to a lab medicine person,
Yeah.
it would be open to the Sunshine list.
But you're talking more about the generality of radiologists working in
Yes,
institutions.
before inpatients, CT, MRI, so any inpatient study was billed to the hospital as a global budget without shadow billing. So it was between the imagers and the hospital, how much they got paid for that. That switched in 2006, where the government said, we do not want the hospitals paying radiologists. We want to pay them directly through the fee-for-service system. So as a result, the fee-for-service billings in the next year jumped because of this artificial change in accounting.
One of the important, that's really very useful information. It also illustrates that every time we talk about this, we find something new, because there is no single repository of knowledge on this, and it has been extraordinarily complex, the arrangements over the years. Thank you.
So we were able to allocate just under $8 billion in payments to physicians, and this is how it broke out among the different specialty groups. 39% to family physicians, which is wonky up there.
So it's 2009. 2009?
Yeah, this is
9/10.
2009-10, yeah. So GPFPs are the largest group. I mean, they make up about 40% of all physicians in Ontario, so they get about just under 40% of the income. And surgical specialists are next with 18%, then the medical non-procedural, which is also a large group. And I don't have the figures on hand as to what proportion of physicians, but there's a little bit of a mismatch there, and you'll see that a little bit later. And then the imaging specialists get about 7%. So this is mean payments per head in unadjusted dollars by group. So the one at the top of the list is the imaging specialties, diagnostic radiology and nuclear medicine. Next one down is surgical medical procedural specialists, and then surgical specialties. Sorry.
No, it's okay, I'm just
I'm in the
reading
way
the
here.
legend of development.
Anesthesiologists are in the middle, in the pink, and then at the bottom are the non-procedural medical, the emergency physicians, and GPFPs. Not in that order. The interesting thing is that the relative position has remained almost constant. There's been a little bit of a shift with the emergency physicians, but the rest of the groups, the relative order has remained pretty similar.
That vertical axis, just in case you can't read the numbers, on the
Is-
far left side,
Is 600,000.
isn't at the top.
Yeah.
It goes
Yeah,
down
this is
by
$600,000.
increments of 100,000,
Yeah.
so you can work it out.
What's your explanation for that big drop in 2000?
Yes, the explanation is the discontinuation of the combined fee. So prior to 2000, there was a combined A-code fee that the radiologist could bill, which combined the technical and the professional fees. Like, we've taken out the technical fees, but we didn't try to split up the A-codes. And so that's what it is. Once the A-codes are taken out, you can see what kind of a contribution that made to
Do you want to say what a technical fee is in this context, just for people who are not familiar with it?
A technical fee, so for certain procedures and for imaging, a lot of them have two fees associated with them. One is a technical fee, which is supposed to go to the facility. It's to support equipment, technicians, all the things that you need to be able to perform the procedure. And then the professional fee goes to the physician who reads and interprets the test. Have I got that right?
Yeah, the technical fee is only associated with certain imaging procedures.
That's right.
Plain radiography, ultrasound, all the nuclear medicine procedures.
Right.
CT and MR, which is the bulk of imaging billings, do not have a technical fee.
Okay.
They are funded through global, but
Right.
global funding through the hospitals.
Because they're always located in a hospital, because it depends where the procedure is done, right?
They are not always in a hospital, but they
Okay.
are global budgeted through the ministry.
And
The
they're-
technical fee does come to the radiologist.
Okay.
They usually, and based on agreement with their imaging facility, they usually turn over
Right.
all of that technical fee to the procedure, and in many cases now they turn over a portion of the professional fee to the imaging,
Okay.
because obviously these technical fees are another issue where they really haven't increased, so if you,
Okay.
so some radiology groups turn over part of the professional fees to the imaging center.
Okay.
The
And
same,
then there are also other clinical procedures that have,
lung function tests, for example, most of the community labs, the professional fee gets contributed to running the lab.
right,
So that
right. And procedures like ECGs and some other procedures also have technical fees associated with them, and they're also excluded from this. So, any other questions? So we're moving now from the group specialties to the individual specialties. This is the average payment per physician for 2009-10, and this is the relative position. So the radiologists, the ophthalmologists are up at the top. Emergency department physicians are second from the bottom, and psychiatrists are right at the bottom, but again, that needs to be taken with a grain of salt, because there's quite a bit in the way of mental health payments that we were not able to get. So that's an underestimate. Yeah.
So my ISIS salary would put me down on the floor. So are we to interpret this as, are these salaries, or are they, there's
Remember,
more.
these are gross payments, right? And out of this, physicians will have to pay for their office and their
Right.
rent, depending on their situation. And the estimates of operating overhead range from anywhere from 15% to 40%. So
You know, that's really dependent too on whether it's in the community or in the hospital.
That's right.
Because hospital-based specialties get huge things that
Yeah.
are part of the institution, and it's difficult to separate, well, what's necessary for patient care,
yeah,
but if it wasn't there for patient care, you wouldn't be able to bill anything,
that's right.
right? So there's huge amounts among hospital-based practice that would never show up.
Yeah.
And the other question is the overhead that attaches to each of these specialties, what's the fixed and variable component to it? It's unlikely that it rises in proportion, strict proportion to the number of patient services and the total billings. There'll be a fixed component and a variable component. Very hard to find how that breaks out and how it changes with that. And just Brandon, we're thinking of moving to a similar system. We're going to charge you rent for your office. Sorry, just pop that one in.
Okay.
Sorry to let you know.
I'll move into your big office.
There's actually another contextual factor here. You're starting at 92, 93. Well, in Canada, in 92, 93, we were paying about the same highest marginal tax rate as in Sweden. Now we pay, our highest marginal tax rate is lower than anywhere in Europe, except in the UK, which really isn't Europe anyway. So, you have to take, I mean, it's not just that there's inflation and changes in GDP, but in fact the whole society is paying fewer taxes.
Right.
And so one of the questions is, these people who get the money, they're paying fewer taxes. All the patients we serve are paying less taxes. And so when you also have to look at the increase in the budget
Right.
for these physician payments, given that the taxes per individual are crashing.
So the pool of money out of which these payments come is getting smaller?
No, it's not
or
getting smaller
not?
because of things like GDP and
Okay.
but in fact, both the physicians and the beneficiaries are paying a lot less tax over their basic
So an increase is a bigger increase,
Oh, yeah. Yeah. And also the increase in tax revenue to do this is not increasing as it would have if we were still paying Sweden-type rates.
But Larry, that applies to everybody in society,
Right.
and it applies equally to the different specialty groups here. So I think it goes beyond the mandate that we've got, which is to
Well,
stop
I'm not
that.
suggesting it's just that it's context.
It's context for sure.
Because like if you had a way, which you don't, of looking at net income after taxes, the increases would be much greater.
There have been some studies of physician income, but the issue that we wanted to get at was physician income from public sources. We don't care what they get from their investments or stocks and bonds. It's from public sources.
And the Canada Revenue Agency is not sharing this information.
No.
Yeah. I don't mean at an individual level. They're not sharing it by group, as far as I understand it.
Sue?
Yeah.
If one of the caveats in interpreting that slide is that one needs to discount these by some unknown factor because of overhead, when you go back to one of your methods slides, you excluded payments from the gap that were infrastructure related. I assume it was
Right.
probably for family practice teams.
No, it was only for specific, it's mostly for family health teams and for academic health science
So why did
groups.
you exclude those? In one sense, those are other components of infrastructure are built into all of the other billings. So why did you exclude funds that were targeted at infrastructure and that's part of the overhead with which we're supposed to interpret this slide?
Because they're not actually overhead for the physicians, they're overhead for groups. So it's a different kind of overhead. It's not the kind of overhead that a physician would be paying out of their billings, for example. It's to for family health teams. The physician, I don't think any physicians here are going to be paying for dietitians or for for a whole range of non-physician specialists or non-physician providers. So it's a different scale and it's a kind of a different context.
That's not entirely true because a lot of the academic surgeons or not surgeons, academic physicians will be paying into a group practice. So
Right.
and then from that group practice they pay clinic nurses and other things, and so there is a significant percentage of their income that goes towards that, and it also gets redistributed to other people as income also.
And the amount of the administration payments that we excluded, it's pretty small.
So we need to, I think we need to
Yeah.
watch time. If
Yeah.
those of you who want to know what the top 10% of unmarried ophthalmologists are paid, will need to let us move on to the slide deck.
Thank you. Okay, so this is just a brief, something to keep in mind, because I'm going to be showing a series of distributional slides showing the medians and percentiles. And just, in this slide, it looks, when you see that the percentiles are spreading out as the median goes up, it looks like the distribution is getting wider. In absolute terms, it is. In relative terms, it is not. So that's just something to keep in mind, that the relationship stays the same, even though it looks like it's spreading out. I won't spend any more time on that.
Just can't get away with the dollars.
Now that was a slip if I ever heard one. Okay, so starting with the individual specialties, cardiologists are one of the top ones.
Any comments?
I just saw credibility now.
I included this for all the cardiologists that I knew would be in the room. And the relative, as well as increasing by about about 2/3, from about 300, although it dips down a little bit here, to about 500,000 a year as the median. It's also spread out. This is one specialty where the distribution has spread out. The 90th percentile has gone from being approximately 1.7 of the median to about 1.9. So it has spread out a little bit. Yeah, looking, let's see. There's a little dip here. This is also the result of that discontinuation of the combined fee. There are some procedures that cardiologists do that were affected by that. And sometimes you'll see a bit of a dip here at the end. That has to do with, sometimes monies are paid late. So in actual fact, some of the money that was paid here probably should have been paid in 2007. But it was paid late, so it shows up in the 2008 year. And I didn't have enough information in order to be able to adjust that. But it's not that it's declined in 2009, it's that 2007 was too low and 2008 was too high. So here's your ophthalmologist. Again, the increase is about the same in the median as cardiologists, but the shocking part is that 90th percentile. And we're going to be doing some more work on trying to figure out what's going on here. We've done a little bit of an analysis of what's driving the increase here, and it appears to be an increase in the average number of services being provided, rather than an increase in the prices that ophthalmologists are being paid.
Yeah, I think that's the most important point. Because both the key specialties in this survey are ophthalmologists and radiologists. And those were the two specialties that were hit by the waitlist strategy.
That's absolutely right.
Even though those were the two specialties that had the lowest increases over the last 10 years in actual fee-for-service through the negotiations.
That's right.
So those ophthalmologists, radiologists really got hit heavily by the waitlist strategy.
Right.
Yeah, and it's a really most important point. You can't increase the number of ophthalmologists quickly, so the extra work has to be done by the existing establishment. And you can see the numbers of ophthalmologists, and the numbers in brackets of the years below really didn't change. You might feel differently the sticker shock effect of the same number of procedures being done by double the number of ophthalmologists, reducing that by half with a completely different impact visually and emotionally. But in terms of society getting services provided, it's the same effect and the same total cost. It happens to be distributed amongst a relatively small number of people. Did you expect them to do it free of charge? It's really important not to react. We've got to think We've got to think our way through those things and make sure people aren't getting fingers pointed for something that they responded to because they were asked to do it
Right.
by
And
society.
some of the
It's hard.
investments, yeah, and some of the wait times investment money went to hospitals who've used it to make procedures more efficient as well, so that more of them can be done in the same amount of time. And so that's what we're seeing here.
And technology has changed and made certain procedures
Yeah.
easier.
So here's your radiologist, and we've already discussed this. So you're saying, so some of this increase is due to the fact that they're billing directly?
Yeah.
Yeah, okay. That's helpful to know. We didn't know that.
And the other thing, I actually disagreed in your report relating to radiologists, is that you said there's quite a dispersion, and you made the assumption that that was based on part-time, right?
Yeah, and I think we didn't have any evidence for that.
Yeah, and I don't think you do.
Yeah.
Radiologists are one of the few physicians that all practice in groups in Ontario.
Okay.
So for here, we have 36 radiologists, and as a result, they subspecialize within their group. So there will be a person that just sits there and reads MR brains all day, which is a fairly well-compensated fee. And there'll be another person who reads mammograms all day, and is a very low-compensated imaging study. So as a result,
So
even though they group their billings,
Yeah.
you get within each radiology group a great dispersion
Yeah.
of billings a month. So a mammographer may only bill $100,000 a year because it's a poorly compensated procedure, whereas someone who just sits there and does CT and MR will obviously be at the higher end.
And another thing to
And then
note,
sharing, obviously.
And that is then redistributed within the practice,
Within the practice
by some
plan.
formula.
And every major medical center in Ontario has that system.
okay. Yeah, because the dispersion is actually identical in 1992, 93, and in 2009-10, relatively. It's the 75th percentile is about 1.3, and the 90th percentile is about 1.7 of the median, and that's what it was in 92. So the relative distribution is very similar. Okay, and so general internist, this is one of the non-procedural specialties. Very, very, very flat. But then there's been some interventions more recently through the academic health science centers and through other mechanisms to try and bring them up to a little bit more parity. And it's actually that their distribution is actually narrowed a bit.
Is it possible you accounted for some people who just do some locums? Because your 10th percentiles is almost
Yeah, I'm not
get
sure.
the no salary.
Yeah, I'm not sure. That's possible, or it's possible some of them are being paid through the hospital primarily.
This is
Through the global
Brandon
hospital.
He doesn't feel his ISIS remuneration is sufficient. He's passing himself off.
I think more than the lowest number.
This is kind of one argument for having a floor, a threshold, yeah. And endocrinologists, similar. They've actually increased, I think the increase is about 72%, 75% over the time frame. Okay. Okay, GPFPs, and then this is, I'll just,
That's important.
yeah, I'll just show this one. This shows the growth in payments and the changes in payment structure for physicians in the different primary care models. The dark blue is fee-for-service. The light blue is capitation. So you can see these are the FOs. This is now the most popular model in Ontario. You can see why. And so there's been very little change for those who are not in a primary care model. That's these over here. They've seen very little increase over the time period. Okay. That's just sources of pay. Okay. Over to you.
We should probably move fairly quickly through this. We've
Okay.
covered, I think we've covered most of the points. The total physician supply has increased in a manner that's really commensurate with population growth without adjusting for age and other demographic changes over that time period. What we're seeing, and I think it's underscored by the discussions today, are that most of what we're seeing in terms of changes can be linked to agreements that have been made between the OMA and the government. They were deliberate, they were intended. We're seeing intended effects. The magnitude of growth, the wow factor and so on, aside, because that is a function in part of how many there were in that group that was asked to respond and provide more services. But most of what we're seeing here is a result of quite deliberate and clear government policy shifting from this period of capping, outward migration and other problems with physician supply to a period of engineered growth, which favours some more than others. I don't think I'll go through all of those conclusions at the moment. I think the thing that is most striking is, in a positive sense, is now the retention of doctors in primary care in Ontario. They're really, I think the province, looking back, was facing a real problem in terms of numbers, retaining numbers, that their satisfaction with the work, their enthusiasm for remaining in that style of practice. I think that's changed. And the largest increase in total payments, notwithstanding what we've seen in these distributional curves, is to primary care, which is an increase of about $1.5 billion. This has been very deliberate, very clear. It's had an impact in terms of retention. But, and this is another report coming on that a number of you are involved in, Rick Glazier couldn't be here today because he's discussing it, the other report with the ministry all day today, is what impact has that had on the services provided to the public by primary care and actual live experienced access to primary